Our next speaker, which is Dr. David Greenberg, who is a lecturer at the University of Toronto. Now, I want to share something with you before I read his bio. I've known David for a long time. You'll note that it talks about the University of Toronto. Well, that's where I did my university studies, some of my university studies. And while I was there, you may have noticed in the program in my bio, I'm a fitness instructor. And back when I was teaching, when I was in undergrad and grad school at the U of T, David used to come to my lunchtime fitness classes. So every Tuesday from 12 to 1, David would shut his clinic, tootle down the street, and come and do my high-low impact workout. So big round of applause, because David was a faithful, walking the walk, living the healthy lifestyle, making sure he got, yeah, look at that. So, So when I was visiting my family in Toronto a few summers ago, David and I met for lunch, and he told me all about the men's health guidelines that he had been working on. And so when we started planning this year's conference and we were looking at chapters of a healthy life, we started talking about the importance of making sure we had a speaker in men's health. And who should I think of but one of my favorite aerobic class participants, Dr. David Greenberg. So David, it's great to have you here.
And that's enough. You don't have to read it.
That's enough? Well, no, but there's so much more. Okay, all right. Well, the details are in your program, but needless to say, David has done amazing work. He's a member of the Department of Family and Community Medicine at St. Joseph's Health Centre in Toronto. He has a special interest in men's health. He's helped to develop and implement educational initiatives for both the public and physicians. He was appointed as a director of the Canadian Society for the Study of the Aging Male in 2003, and in April 2008, he took on the role as president and continues in that position today. In 2010, he initiated the process that led to his role of chair of the Canadian Men's Health Guidelines, part of the highly respected MUMS Salmon-Colored series. The guidelines, which are now published, have been reviewed to wide acclaim by experts and primary caregivers alike, and are the foundation of what has come to be known as the Canadian model for optimizing men's health care. They will be distributed to all primary care practitioners in Canada, and in so doing, the guidelines will ensure that they will all have basic knowledge required to care for the issues relating to men's health. Dr. Greenberg is a charter member of the American Society for Men's Health, and he's also a director of the Canadian Men's Health Foundation, an NGO founded by Dr. Larry Goldenberg to promote the health of men of all ages across Canada. Now, David mentioned he's concerned that I'm taking up the time because he's got a lot to cover. Development and implementation of the men's health guidelines for family practice, and then the alpha male, how to care for the man who doesn't think he needs your care. Ladies and gentlemen, welcome Dr. David Greenberg.
First of all, I want to thank Jennifer specifically and the committee in general for inviting me here. This is an amazing event, and I can only hope that they'll come up with some topic for next year that I'll know enough about that they'll invite me back again. This is really, I'm not sure what. I hope maybe we'll consult before they pick a topic. I have 3 challenges today. The first challenge is I'm giving about 2 hours worth of talks, and I've been told that I've got exactly 45 minutes. So I may speak a little quickly, and I may hop over a couple of things, but I will be available if anybody wants to discuss anything. The second challenge is that you'll notice that some of the slides and some of the things I'll be speaking tend to be directed towards medical practice, to physicians. I want everybody to know that everybody's included, and if anybody has any questions, I'm sure it's just wherever it says we, I'm talking about us, not just about doctors, okay? So if you're here and you're not a physician, thank you for coming, and we're all gonna work on this together. And the third challenge is that I'd like these talks to be interactive. And in fact, the second talk, I'm actually gonna need your help. But I know sometimes people are shy about, speaking up in these kinds of events. So I think it'd be more comfortable if we just introduced ourselves. So if we could start in the back corner there. Do you want to just stand up and... I'm kidding. That'll take the whole 45 minutes. Okay, so I'm going to be talking about two very, very different topics today that are exactly the same. But the difference is that the first one is a program that we came up with, and I'm really going to give you the very bare bones of this, that is helpful now. The second is something that we're hoping through further research will become more helpful, but I think it's as food for thought, it's going to be interesting, and it's a lot of fun to talk about, so we'll just move along quickly. So I'm going to talk a little about these men's health guidelines for family medicine, and as you can see in the bottom there, and as Jen was kind enough to show you what they're going to look like, this salmon-colored series is something that's very, very popular. They also call it the Orange Series. Anybody here ever seen the anti-infective guidelines that come in a book that looks like that? They're quite popular, at least in Canada and other places where I've spoken around the world, people seem to be aware of them. And so let me just talk about very quickly about why. So the original impetus came from CSAN, and as Jen was kind enough to point out, I was made a director of CSAM in 2003. I went to the Lou during a meeting in 2008, and I came back and they'd made me president. You have to be very careful about that. So basically what happened was, it had occurred to me, there were three things that had occurred to me that why we needed these guidelines. The first was a day, I know there's at least one person here from Guelph, or at least there was at the bar last night. But Guelph, Ontario is a relatively small city about 45 minutes from Toronto. My daughter's in university there right now. And this couple, an older fellow and his second wife, came to see me because they wanted to get his testosterone tested. And he couldn't find a doctor in Guelph that would test his testosterone levels. I can't tell you how many doctor's offices you have to drive by to get from Guelph to my office, but trust me, it's not a small number. How he found me, I don't know, but he found me and we had a nice chat. And as luck would have it, there was a lovely young woman there who was in fourth year medicine, which is the final year at the University of Toronto. And I said to her, how much time have you spent during medical school talking about men's health? And the answer, of course, was 0, exactly. So that was the second thing. And the third thing was, there's a famous medical publishing company called Elsevier. Have you heard of them? Okay. Anyway, for several years in the 2000s, what they would do was they would take a book of guidelines, and then they would cut it down into what the word I learned was they excerpted them, and they would send them out to 22,000 general, what do you call them, GPs or family docs here? GPs or family docs is the Caymanian GPs. So they sent it across to 22,000 GPs across Canada. And then they asked me to be the editor, which was really very nice of them. And in the first year, we sent it around. And when they asked about topics for the second year, I said, why don't we put in something about what we called in those days andropause? We try not to call it andropause anymore, and I'll explain why later. But bottom line is, so we put that in, and it was one of 32 topics that were in this book. And in the follow-up, people going online to ask to get further information, of all the 32 topics, the only one that got more positive feedback and more interest was congestive heart failure. So we've got two problems. We've got a need and we've got a desire, so it made perfect sense to put this together. The reason I went to the mums people to create an Orange Book was because it was already an established, incredible thing. And for those of you that are concerned about such things, they're completely above any pharmaceutical interest. These are completely developed by practitioners and academics and pharmacists, and we just do it. And this modified Delphi approach is really, really interesting. So what happens is the people who run mums, who are pharmacists, they put together all this literature. And they look through everything, and then what you do is you strike a planning committee, and you send all of it out to the committee, and then they send their comments back. But the comments are blinded. Nobody knows who said what, so nobody can exert any undue influence. And then what happens is we look at them, collate everything, and send them back again. And we keep sending them back and forth until we know that we've got what we need. So it's completely anonymous, and nobody can exert any influence. So it's a really, really good approach. And this is how we did it. And the formatting thing is really important. It's a 10-second rule. If you want to have a look at one of the books, you can see that whatever you need to find, if you can't find it and look it up in 10 seconds, then we've wasted our time. Because that's about how much time most people have to find things. And interestingly enough, What's our major competition today? Everybody? Google, right? Somebody sent me a cute poster from my office. I didn't hang it up. It says, please don't confuse your Google search with my medical degree. But it's actually, if you have a book, if you have a proper book where you know where things are, it's actually much easier to, it's actually much faster than the internet. So this is actually an efficient thing. Everybody said, well, you need electronic copy. Trust me, this was actually very useful, and a lot of people have these books right on the anti-infective ones for sure have them right on their desks. Okay, so there we go. So these are the topics, and one of the things that we talk about in men's health that's really important is we have to remind people that men are more than just penises and prostates. There are more things that I know some of you are thinking, well, geez, not a hell of a lot more, and I get that, but you know, in terms of like differentiating men's health from women's health, there's more to it than just those parts. So you can see that there are a bunch of things that have actual men's components to them. So this is what it looks like, and you can see a couple of things here. Oh, I can look here, right? So one of the things you can see is that it gives you a clinical scenario, it gives you what the likely causative agents are, it gives you what drugs are appropriate, and it tells you what the costs are. So you can, if cost is something that's a concern to you, you can even do cost comparison. And the notes at the bottom, I don't want to say that it's a primer in terms of like, it doesn't replace a textbook, but it's got a lot of really great information. So even if you know nothing about the topic, it can be really, really useful, and that's what we're sort of hoping for, is this will become the baseline. This will become the lowest, I don't want to say lowest common denominator, but that everybody across Canada will now have the same information so that people won't have to drive 45 minutes to find one doctor that knows something about what they're asking about. So these are just some more sample pages, and you can see, you can't read it obviously, but there are lots and lots and lots of notes, and the kinds of things that really provide lots of education. So there's a couple of questionnaires in them, and this is something that I developed. And when I presented this originally in Prague, I was given my usual time slot, which is the highly coveted 5:30 on Saturday time slot. And, but it was actually quite well received again. And you can just see, this is called the Men's Health Assessment Form, and you can see that it's broken down into a few areas that actually allow you, if you're doing general practice, you can fill this out and drop it in a fax machine and send it to a specialist rather than what the specialists always complain about, which they get, which is 65-year-old male, please assess. You'll get much better information if you provide more information. So you can see that we're looking at things that are relevant to men. You can see that what we ask for is a patient's story. Because I find, and I'm sure some of you find, that when you put it in the patient's own words, that's when you get the best information. There are a couple, these are some, let me just go back here for 1 second. So do you see the numbers next to andropause, which I have to change? Erectile dysfunction, see those 1, 2, 4, and 3? Okay, so basically what those are, those refer to validated scales that are at the bottom here, and depending on what's wrong with the person, these are the kinds of scales that are worth filling out in order to differentiate between the kinds of things that it might be. So low testosterone, for example, is something that can be mimicked by a lot of things, up to and including depression, hypothyroidism, lots and lots of things. So by filling out a depression scale, we're going to change that probably to PHQ-9 for those of you that use kinds of things. ADAM questionnaire, which stands for androgen deficiency in the aging male. Not a great measure in terms of what they call specificity, but very good in terms of sensitivity. It's not great at telling you exactly what's wrong with somebody, but it's really good at telling you if there is something wrong with somebody. Then there's the IPSS scoring system, which has to do with prostates, sexual health inventory for men, and so on. So this comes with the book, and I'll just keep doing that. Perfect. Here are the kinds of things that we do for an exam. And at the time, the fellow who wrote the ADAM questionnaire, when he saw it for the first time, he said to me, David, this is terrific, but there's only one problem. And I said, what's that? He said, well, if you fill this out, what am I supposed to do? So that was a really great honor that he said that. But, you know, GPs need help. There's only so much stuff we can do. And hello. Okay. So the PAC program I'll just whip through this, is in Canada, we have different levels of continuing education credits. Do you have that here? Where some are easy to get and some are a lot harder to get. So this has been accredited for the highest level of credits that are harder to get. I've done, I'm actually doing one in Vancouver in a couple of weeks, and I do small groups, a little smaller than this, usually about 30 people at a time. And what we try and do is we've developed some cases that allow people to become familiar with the guidelines. The answers in the cases are keyed to pages in the guidelines, so it gives people a chance to know that. And these are what the 4 cases are. We're on 5 now, right? We came up with a new one. And again, with a focus on men's health and with the answers in the guidelines. And here's the nice part. So we're up over 200 participants now, and the feedback has been phenomenal. These people come in literally knowing nothing about men's health because they've been trained in Canadian medical schools and they don't learn anything. And this is the kind of feedback we've gotten. So it's really, really gratifying. And we also have some measures. Here, these are the cases. So you can see that they're all in the over 80% range for excellence. So really, really gratifying. And just some specific comments. Okay, I'm really trying to go. So, again, the key point in the first bullet point is it assures that we're all on the same page, and the third bullet point is really what it's all about, which is really what the second talk about, is that education, as you all know, is not about transferring knowledge. Education is about changing behavior. Does anybody here think that anybody isn't aware of the fact that smoking is bad for them? Okay. Has it helped? Not a hell of a lot. Okay. So, hello. Okay. So now we've secured funding, and much like this, which is brilliant in that it's free, it's been my life dream of the last several years to make sure that every single GP in Canada gets a copy of this for free. And that's where we're at, and hopefully we're on track for that to happen by the end of 2016. And then what we've come up with are some metrics so that we can actually gauge if people are using them and how useful they really are, not how useful they think they are. I thought we hid these. Okay, we don't need these slides. Okay, so that's the guidelines story. What time is it? Okay, excellent. Okay, so that's a guideline story. I brought a few copies if people want to have a look at them. More than happy to discuss them. I think that in terms of like right now, as of October 22nd, opportunity to actually intervene and have a meaningful impact on the health of men in the Caribbean. Oh, we're already working with, listen to me, I sound like a real jet setter. I'm flying to London to meet with a group, so they're going to be distributed in the UK next year. There's a group in Malaysia that's going to distribute them. There's a group in India that's going to distribute them. So slowly but surely, from my little office in Toronto, I'm taking over the world, so I'm kind of happy. No, but it's really, it's an amazing, amazing thing because it's this insane need and people are finally starting to recognize it. So anyway, more than happy to discuss that with you at greater length afterwards. So let's go to the black screen and a little music. And now we're gonna, so this is the talk that got a little bit of a giggle in the introduction. Thanks again, Jennifer. So this is what we're going to talk about. Anybody here know any alpha males? Oh, raise your hands for God's sakes. I told you it's supposed to be interactive. Of course you do. We have one alpha female self-described in the room. I'm not going to point her out, but she knows who I'm talking about. Okay, so here we go. Disclosure of commercial support. I have nothing to disclose. Okay. And the committee was kind enough to bring me here, so thank you again for that. Okay, so this is a very, very important slide, okay? Just want everybody to take. Okay, we're never in the right frame of mind now? Excellent, okay. All right, so why do we care if men go to the doctor? It is kind of serious, actually. So here we go. You're going to hit that? There should be some volume.
men are much more successful. Men are 85% more likely to die of arterial disease than women. Men are 40% more likely to die from diabetes. Almost all workplace deaths are males. Women outlive men by an average of 4.5 years. Men live 10 unhealthy years. And 1 in 3 can't see it.
There's a great joke that goes with that. A patient goes to the doctor and he's got this big panus of fat, and the doctor wants to examine his genitalia, and he pulls him out of the way and he says to him, "You know, sir, you really should diet." And he says, "Really, what color?" Anyway, okay, so there's a couple more stats that are really, really interesting and important and why this is so meaningful, okay? That stat about so men now live about 10 years longer on average than they used to, but almost all of those years are lived in disability, okay? This is the problem, keeping men healthy until they hit the end of the road, okay? We did a study last year. Now remember, Canada is about 1/10 of the size of the US, so if you want to think, if you're more comfortable with US dollars, in Canada in 2015, we could account for 37 billion with a B Canadian dollars directly and indirect costs of the healthcare system by men making stupid choices. Okay? If they would eat properly, exercise more, drink less, and stop smoking, we could save $37 billion a year. That's just money. That's not talking about heartache, okay? That's not talking about, that's even including the money that goes to people that have to give up their jobs to become caregivers instead of doing important constructive things. Not that being a caregiver isn't important and constructive, but it's completely unnecessary. So this is why this is incredibly important, okay? So why don't men see a doctor? Everybody's got a theory. These are the ones that we came up with. There's personal barriers. People just don't like to go to the doctor. They feel vulnerable. I mean, a lot of men. And one of the interesting things about practicing medicine in Toronto, there's a hospital that I used to be the chief of family practice at. They closed it, of course. And we used to say we looked after people in 120 different languages. So to be able to become familiar with the cultural differences, you know, what some people will tell a doctor, why some people will go to a doctor, and why some people won't. Interestingly enough, to speak to people in their own language, because there's a lot of times that there are words that just don't translate very well, or they just don't feel comfortable. The first time I learned about one culture was, I was a medical student, and there was this Scottish woman who was there to have her bowel resected, to have her bowel basically cut out because it stopped working because she hadn't had a bowel movement in 25 years. Or a proper one anyway. So the question came up, so Mrs. Scott, why didn't you say anything? Oh, doctor, we would never discuss anything like that, right? So when you get somebody who comes in from the British Isles, especially you got somebody who lived through wars and the Depression and so on, they're just thrilled to be alive. They don't complain about anything. By the same token, if you get somebody who comes in from one of these cultures where machismo is valued, and they want to talk about psychiatric issues, you better take that very, very, very seriously, because they don't do that very easily, okay? So they don't like to give up control, and they, as we said, they don't like share price. So what are the systemic barriers? These are problematic all around the world. I try my very best to stay on time, but for people that are working in hourly wage jobs, you know, it costs them a lot of money to come and see me. And I try my best not to inconvenience them, but I mean, I gotta have a life too. No, in terms of like people, you know, people often say, well, can I come after work? It's, well, what time do you finish work? 7 o'clock. It's like, you know, I got kids, but I try. Lack of male healthcare providers. You know, the average medical school class now in Canada, over 50% of all the graduates are female. So, and of the preponderance, you know, that basketball that's moving through the snake, that whole generation of males that went through years ago, they're retiring now. So it's getting harder and harder and harder to find men doctors. And not that that's necessary, just other than for comfort. And again, taking time from work just to care for themselves, forget the money, right? And this is gonna come up more. So let's just say a miracle occurs. We've got a couple of miracles coming up in December, one for those people and one for my people, for those of you that are familiar with these things. And a man actually shows up at your office. So, given what we know about men, again, as I said, it's about changing their behavior because it's their bad behavior that accounts for most of their problems, or many of their problems. So, who's great at changing behavior? Start thinking about this, because I bet you're wrong. Or maybe you're really smart and you're right. I'm sure you're really smart and you're right. So, healthcare providers like to think we're pretty good at it. Any evidence to the contrary notwithstanding, I'm sure this guy's somebody that you're all familiar with in some way or another. But here's who's great at it, okay? They're who's great at changing behavior, okay? Now, I want you all to take a look at the I hear there's no Starbucks yet in the Caymans, right? It's coming, I'm sure. So I want you to look now at that coffee cup, okay? So that's Sarah's coffee cup. I don't know who Sarah is. She's probably not even a real person. Some marketing person probably came up with her, okay? So Sarah is not a person. Sarah is a double tall extra foam caramel macchiato, okay? Now, I promise you, with all my heart and soul, that 10 years ago, Sarah didn't even know what a caramel macchiato was, okay? But in 30 seconds or less, Starbucks has figured out who she is, okay? Now, here's a good question for you. How many drink choices do you think there are at a Starbucks? Have anybody been here in a Starbucks, even though you're not from, they don't have them here? Raise your hands if you've been in a Starbucks. I just want to make sure you're all awake. Perfect. Okay. How many drink choices do you think there are at Starbucks if you include all the combinations and permutations? 84,000. 84,000. And Starbucks, in 30 seconds, has nailed down Sarah's order, and with a minute and a half, she'll be on her way. That's extraordinary. They're way better than we are. Okay, so how do they do it? This is the key. They know their customers and they tailor their messages. They tell them what they want to hear in words or images that will speak directly to them. So they created a double caramel macchiato for Sarah to now think that she needs and wants, and she heard it and she goes, wow, I better try one of those. That's who she is now. So here's our old friend Steve Jobs coming up to us from the grave, and what he said was, a lot of times people don't know what they want until you show it to them. So most of market research is reactive, right? We ask people what they want and we try and give it to them. Steve Jobs did it the other way around. Steve Jobs thought, this is extraordinary, this is amazing, I'm gonna make people want this because everybody should want this, okay? Health can be that. Okay, so it applies to retail sales as well, and how does it apply? Because what we're in is in retail sales as GPs. Because every day when I go to work, it's my job to give 100% of my customers, we call them patients in my business, a satisfactory experience, not necessarily an outcome, mind you, 100% of the time. Okay? That's retail sales. You get on a phone call with your cable provider, right? And what do they always ask you at the end of the call? How was your experience, and is there anything else I can help you with? And often I've had to say, or felt like saying, much like you have, well, you haven't helped me. But you can have a good experience even if it doesn't work out, okay? And you want men, if they finally come to the doctor, you want them to have a good experience. Why? Maybe they'll come back, right? Okay, so we deal with a big number of people and a variety of people in a limited amount of time. How do we do what Starbucks does? How do we get to know them quickly enough to figure out how to reach them? So this is through the very efficient way is through the use of archetypes. Raise your hand if you've heard the expression archetypes before. Perfect. Okay, so lots of you are going to enjoy this. Okay, so Identifying an archetype and tailoring a message is not a new concept, and I'm going to show you a picture. This is, again, from my co-religionist. This is from the 1200s, okay? And this is a picture of the 4 sons, okay? Or the 4 children in this one. And basically, this happens at Passover, and there's a Seder, which is a very, very overwhelming meal that is based around Jewish people acknowledging their coming out of slavery in Egypt. If anybody here has ever seen the Ten Commandments, that's basically the movie The Ten Commandments with Charlton Heston. That's basically what the Seder is. But here's what they do. They tell you how to identify 4 different types of children, and then not only do they tell you how to do it, how to identify them, they say to you, this is what you need to say to them, because this is what they need to hear, and this is how they will hear it. So this concept is way over 1,000 years old, nothing new here. So how do we see them in advertising in modern times? It's very common. We have what they call aspirational archetypes, the people you want to be like, okay? So there's the Marlboro Man who unfortunately passed away from lung cancer. That actually is true. And before he died, came out and said, smoking is really bad. It's like, yeah, thanks. And then, of course, there's this fella who some of you may recognize. That's Tiger Woods. And the answer to the question is, how far can Tiger drive? Was about to the end of his driveway when he ran into a tree and 14 women fell out of the tree. So these are the relatable archetypes. These are not the people that aspire to you. These are the people you look at and go, yeah, they're just like me. And, you know, my daughter's at university now. I'm sure that this is going on there, but she doesn't drink, so it works out fine. So I said before, there's nothing new under the sun. We talked about archetypes, but identifying a potential customer as an archetype and then tailoring a sales pitch based on that is a strategy commonly used on GPs by pharmaceutical companies. And they do something called consultative sales. And for those of you that aren't physicians, you will get this in other aspects of your life. You will get this in retail. Women, you'll walk into a store and their personal shopper will come up to you and say, hi, can I help you? And you'll say, I'm just looking for. And she's going to size you up in about 12 seconds and figure out what size you are, what you're looking for, all those things. That's called, okay, so, hello. Jen, you got to give me an extra 2 minutes for this not working. So there's something called the Myers-Briggs archetype. Sometimes I call it the Baskin-Robbins archetype. But anyway, if you look around this, there's a bunch of different people that, by recognizing, and this is the thing that makes it easier, if you can think of somebody who exemplifies that kind of person, then when they walk in, you go, I know you. You are Mahatma Gandhi. You are Mother Teresa. You are Jackie Kennedy. And all the attributes and all the things that go along with that are all captured in that one name. Okay? We'll see more. See how it applies to men's health. Okay, and in medicine, and people do this in everyday lives all the time, right? You meet somebody new, and we stratify them by age, by sex, by the socioeconomic status, by their educational background. So basically, when you see somebody on the street, or you're introduced to somebody, you're taking in tons of information. How they shake your hand, how they speak, how they're dressed, do they have an accent? And you're making all kinds of simultaneous decisions about who they are, and you're probably augmenting your behavior or changing your behavior to make it more comfortable to speak to them. Okay? People do this all the time. When you meet somebody new and you start a conversation with them, one of the most common questions we ask is, so what do you do? And then once you find out what they do for a living, that's poetry. It explodes. You know what their education level is, you know how much money they make, you know if they get dirty or not. Like, there's a lot of things, right? Okay. So, then there's another piece of this called their worldview. And this is how people see themselves in the world and how they relate to it. So you can see that the worldview, which again is something that can be easily informed by very, very brief conversation, can then ultimately lead up the pyramid to their behaviors. What kinds of behaviors would you expect from a person who views the world in a certain way? Right? So if, for example, you know that if somebody is a particularly religious person of a religion that doesn't think that alcohol is okay. Okay, well, now you know they don't drink to start with. You don't even have to offer them a drink. You know that they won't take it. Right? For example, there's lots and lots of things. Okay, so the key for us is to know your patients. And again, for the people that aren't doctors here, if you've got family members, if you've got friends, these are really, really important things. But if we try to get to know them in the context of their archetype, we can actually intervene in a very meaningful and quick way. So, okay. So some research that the Canadian Men's Health Foundation did, fortunately, has made it easier because we've actually come up with a half a dozen archetypes that we're trying to get into a questionnaire that we can give patients when they come in the door. So once they walk in, you'll already know who they are, or mostly know who they are. But, so this is just how it happened. I can skip over that. So like the 4 sons, we wound up with the 6 men, okay? So those are the 6 men, although not exactly as illustrated, but there are 6 different guys. And you can see these guys are probably all about the same age, right? But they're all dressed differently, they're all smiling, but there's enough differences between them that they're clearly not the same guy. So these are the 6 kinds of archetypes, the 6 kinds of men, the 6 archetypes that we've come up with. And you can see we've got denial of vulnerability. And what I'm going to do, now that I've shown you that what the sections of the pie are, I'm going to show you ways that you can think about this going forward that might help make it go faster. Okay, but before we look at each, this is the part where I'm going to need some help with people answering questions, okay? How many people here have ever heard of something called the Prochaska model of change? Raise your hands. Wow. Good for you. Don't worry, it's okay. It's good that you heard of it. So this is the thing, right? If every guy came in and we tried to change everything about them that needed to be changed in one visit, that would be the last visit they ever came for, right? And we wouldn't have any success anyway. So the Prochaska model of change, it shows it here in 2 different formats, is the strategy is, and it doesn't just work for medicine, it works for sales, it works for any time you're trying to change somebody's behavior. The trick is that what you have to do is you can get them to move 1 stage at every visit, then you've got a chance, okay? So you can see their pre-contemplation, they haven't even realized they have a problem yet. Contemplation, they start thinking about it. Preparation, they start deciding if they're going to do something about it. Action, they actually do something about it. And maintenance, which is they continue to do what they've been doing. So I am now going to show you each archetype, and this is where I'm going to need your help, okay? So the first one is learned helplessness. And here's my quote, which is, I guess I eat my way through my emotions. I've taken the approach, screw it, you'll pardon the expression. I don't care about myself, so I'm going to order what I like. So this guy I named Sammy Screw It, okay? Those are the Houston Texans for those of you keeping score at home, okay? So this guy is clearly, he's living large, okay? So where is he on the Prochaska model of change? Where is he on that spectrum? Everybody all say it together. 1, 2, 3. This guy isn't just pre-contemplation. If pre-contemplation is there, he's about where I'm standing, okay? This guy is pre-contemplation, and more than that, he's having a great time, okay? So how do we get this guy, how do we speak to him in words that mean things to him that will get him to start moving towards recognizing the fact that he may have a problem, okay? So the next one is denial of vulnerability, and this is Larry Live Forever. He's quite the stud. And he says, when I think about health, I think about doing anything I want. I can have sex 3 times a day, if you say so, because nothing can slow me down. Okay, again, where is he? Let's say it again, real loud. Pre-contemplation. Maybe not as far as I am, maybe at the BAF insurance sign or something, but he's definitely on this side of the scale. Our next one is called suppression, and this one is probably going to be very familiar to a lot of the people in the room. And you can see that the quote is, acting like a man is doing whatever you need to do to survive. As long as your family is happy, then you need to sacrifice. Okay? Anybody know anybody like this? Anybody actually is anybody like this? Actually, not quite. But so this is Dan Do What It Takes. And that's what he learned. He learned that he's out there, he's the breadwinner, he's the cornerstone, he's the foundation, and whatever it takes to keep his family happy, that's what he's going to do. Now, where do you think he is? Say it louder. At the tower marketing side. I actually think, and that's why I want to talk about this, I actually think that where this guy is a contemplation. I actually think this guy knows that he's killing himself. I think that he knows that he's working himself to death, but he also doesn't feel like he's got a choice. That's what he does. Having said that, I think the pre-contemplation is absolutely a completely reasonable thought as well. And the beauty of this is, there's no right answer. But that's something that he recognizes the fact that when he says that acting like a man is doing whatever you need to do to survive, implied in that statement is that there are things that he should be doing other than what you need to survive, right? Having said that, he's certainly on that side of the spectrum for sure. So now we've got controlled intervention. So this poor guy, this is Al Almost Made It. After my sister had an aneurysm, I started getting tested and went on a really strict diet. I managed to lose 30 pounds, but I couldn't maintain it. Anybody here know anybody like that? Okay, so there's 2 points that are interesting here. One is that when somebody famous has a heart attack or prostate cancer, the phone starts ringing off the hook at my office, which is great. Once you remind the people that, you're not related to these people. But whatever it is that gets them to call is a good thing. So first you take away the shock and awe, and then you start working with them. But here's an interesting point. How many people here in the world have been told that they should lose weight, or think that they need to lose weight, or know other people they think need to lose weight? Raise your hands. Lots, right? Okay. I'm going to tell you something really important. One of the things that I've been doing in my spare time is I spend a lot of time working with elite athletes and professional athletes over the years. And one of the things that I say to people is, so I don't talk to anybody about their weight anymore, save and except for 3 groups. I talk to diabetics about their weight because just by losing weight they can cure their diabetes. I talk to people with high blood pressure about losing weight because you can actually get off medication if you lose weight. And the 3rd group are people like me that have sort of lower limb joint problems, right? You lose some weight and your knees stop hurting and those kinds of things, right? But everybody else I talk to about fitness. I don't talk about weight loss. Why? Because this guy is a perfect example. If this guy loses 30 pounds, so let's say he's 200 pounds in this picture for argument's sake, and he gets down to 170 pounds. When he loses that weight, he's losing muscle and fat at the same pace. What happens when he puts the 30 pounds back on? It's all fat. So at the second 200 pounds, he's significantly fatter than he was at the first 200 pounds. He would have been better off not losing the weight in the first place. And these are what we call, this leads to a condition we call the frail obese. And these are people that are walking around that for all the world look like, these healthy people, these robust people. In fact, they're like the Michelin Man. They barely got enough muscle to hold them up. So that's a really good takeaway. Don't talk about weight loss, talk about fitness. Okay, so let's talk about where he is in this thing. Oh, that went too far. Okay, so this is interesting because one of the things is about this Prochaska model of change is you can show it graphically in a different way. You can show it in a circle. So where is he? Relapse, correct. But the good news is, you see there's a tiny, tiny little space between the arrows and the next arrow? You can always get back in. And for example, there's pretty good research that shows how many times do you think the average person has to try to quit smoking before they're actually successful? If they are at all. 7 actually is the right number, okay? if people said to you, I've tried everything after 5, right? And you didn't know that, right? So now you can say to them, you know what? You still got 2 more shots. It's easy to convince this guy to get his act back together again, okay? So that's Al almost made it. Here, now we're getting into some of the, yeah, there you go. So what's most important is making sure your family gets into a healthy routine with their lifestyle and food habits. That's what came from my dad, and that's what I want to pass down to my family. That's Gary gets it. Gary clearly gets it, okay? So where are we with him? Maintenance. This is the guy we look at and say, man, could you be a donor? I just need you to talk to everybody else in my practice and explain to them this is the way your life should be lived. Okay, then we've got, this is good. So this is Marty, my wife, changed my life. And before my wife, I'd never thought of a diet or exercise as a fun thing that keeps the family together. At first it was forced on me, but now I like it. Unbelievable. When you guys get all the I've been watching in my room, right? How many American sitcoms have you seen with these big fat husbands and these really fit wives? All of them. Every single one of them. It's become a ridiculous cliche, okay? But if the wives are, and I mean, it's pretty clear to me that if wives were able to exert or the influence that they can, the world would be a much happier place. There'd be no more wars, everybody would be in shape. But anyway, so this is a really, really important thing to try and reinforce as well. He's at maintenance, correct? Okay. So you say, David, that's great. But I haven't got the opportunity to get to know my patients in that way because I work in a group. I don't see the same men all the time. So what's coming next, hopefully, and this is research we're doing now at the Canadian Men's Health Foundation, is in fact a sheet like that 4 Sons thing. When a guy comes into your office, or if you want, well, hopefully it'll be online, you can hand it to your husband, you can hand it to your father, you can hand it to your brother, and say, fill this out. And that way the doctor will know what it is that he's dealing with, where he is on that scale, where he is on that spectrum, and how to help move him forward. That's what's coming next. So to summarize, if we stratify our male patients into archetypes based on our own special worldview, we have a much better chance of changing their behavior to a healthier approach, but you already knew that. Anyway, so this is my final, everybody like that billboard? Anyway, that's our logo. I can't thank you enough for participating. It's been an absolute honor to be here. Thank you, thank you. I got through it, and apparently I have some time for questions. Would anybody like to talk to me about anything? Please, please, please ask me questions. I live for questions. We have a question here from Dr. Hospitality.
Thank you, DG. That's how I discovered I'd remember your name, by thinking you looked like a director general.
Thank you. I was going to mention that, but I thought it was a little,
No, thank you for a really great talk on what is a serious subject for us in the Caribbean that we've not been paying attention to. I think I neglected in my talking about next chapter last night. I should have mentioned about men's health, because when you look at the statistics, it's scary. Men are living 4 to 7 years less on average. A lot more risk factors, except in body mass. And something you haven't touched on, they're killing themselves and killing their spouses and their children. So the violence part in the Caribbean is a major piece of it. I think I'd like to discuss with you how we could collaborate. There is a Caribbean Men's Foundation. It's called Cayman. And it may be good to talk about this. We produce guidelines, CARFA that is, and it would be good to talk about Caribbeanizing these guidelines, because there will be some similarities, but there are also some differences with the Caribbean male population. Thank you very much.
Thank you. And as it happens with the UK group, I'm going over there in a couple of weeks to go over that. We sent them a copy of the guidelines so they could Britannize them. So they're really, really, really easy to modify. So that'd be wonderful. Thank you. Yes, sir. There's a microphone coming behind you.
Good afternoon. I'm Dr. Brian Backman. I'm a urologist trained at McGill, worked in Toronto for 15 years before I came to Paradise. I've been here 21 years. One of my biggest challenges as a urologist is a lot of Caribbean males avoid coming in for prostate checks because they say, I'm not going to have that done, I'm not one of those. And that machismo kills. And we have lots of educational programs, and some of the service clubs do talks, and churches do talks here, but we just are having a heck of a time still getting around this. I have actually seen and examined people who are in stage 4 metastatic because they would not go to a doctor, they would not have an examination. I actually had to have someone anesthetized to do an examination of the rectum, did a biopsy, found a cancer, did a radical prostatectomy, and saved his life. But that's the kind of headspace we find here. Not in all, but in quite a lot. And a lot of education to go in on that.
That's really good to know that you're trying, because, you know, if we could teach prostate self-exam, that would be wonderful, but I don't think that's happening anytime soon. No, I think, you know, again, like in this, it takes a second, but it was funny. You know, in this day and age, we're having a big beef right now at home with non-government agencies, non-physician agencies recommending against PSA screening. And it's still the number 4 killer of men. It's a completely stupid cancer to die from because it's eminently treatable in its early stages. And if anybody's ever seen anybody die from prostate cancer, I don't know. I mean, I look after all different guys, not just urology, but I can't think of a worse death than prostate cancer. It's absolutely horrible. Is that enough to scare people? Probably not. It's really sad. But again, can the women help with this one? A lot of the Canadian Men's Health Foundation initiatives are geared towards wives, mothers, and sisters and daughters, to try and say to people like, look, you know, I want you to be around for our kids' weddings. Those kinds of things. But anyway, I'm happy to talk to you about it. If you come up with anything, or if we do, love to stay in touch. Thank you. Where did you work in Toronto? North York General? What year were you there?
1980 to 94.
Then we may have crossed paths, because I was there from 89 to 90. Beautiful. Lovely, thank you. One question over here. Thank you. Hi.
Hi.
Last question, apparently. Make it a great one.
Yes, I want to find out what you, through your practice, what are the top 3 or 4 motivation for men to come into your office? I would like to get my husband into
Could you ask me something easy, like world peace or something like that? Okay, 1 second. I want you to take your hands and put them over her ears, okay? I was going to give you a bit of a... Thank you. Just tell him he's not getting any until he comes to the doctor. He'll be there so fast it'll make your head spin. We're working on strategy. You know what? I don't know what motivates guys. You know, somebody wrote an article. Do the thing with your hands again. Somebody wrote an article in one of these men's magazines, and you know, it was sort of like tips for guys. And one of them said, and one of the tips was, you want to talk foreplay? Do the dishes. You know. So, I don't know, but you know what? If you come up with anything, I'm easy to get a hold of. Please let me know. Thank you.
Another round of applause.
Thank you.